So I'm Kamal Mahtani. I'm a GP Professor of Evidence-Based Healthcare here at the University of Oxford. I'm also Director of the Academic Director of the MSc in Global Healthcare Leadership. And that's partly one of the reasons why we are here. And a little bit about the program. So the MSc in Global Healthcare Leadership is a relatively new program. We took in our first cohort last year, and we are welcoming our second cohort last week, in fact. So I can see some of them in the audience, so welcome again. But the program was designed in partnership with the Nuffield Department of Primary Care Health Sciences and the Side Business School. And it was largely designed as an opportunity to respond to some of the global healthcare challenges that exist, and the opportunity to develop the next generation of healthcare leaders to try and tackle those challenges as well. So this roundtable discussion reflects some of the sort of elements from that spirit, but also gives you a little insight into the sort of discussions that we have in the classroom, but also the experience that the program brings together. So I'm going to introduce the panel to you in a moment, but just to say, the way we'll run this is we will hear from the panel a little bit about their backgrounds, and then we will also hear about their expertise and their experience. We will open it at some point for questions, so do save your questions up. There's opportunities to ask them in person, but also online as well. And then we'll look more specifically at a specific case study, which Muji will lead as well, but I'll introduce that at the time. Okay, great. Well, let's then go on and meet our panel. So can I go around just to say to each panel, thank you for joining us, but also just to say who you are and where you're from and what you do. Let's start that in the meeting.
Thank you very much, Kamal. Nice to see everyone join. I'm a physician. I'm from Nigeria. I currently work with UNICEF as health specialist, leading some programs in the immunization team. And nice to be here.
Great. Thanks.
Hi, it's Kiwana. I'm a medical doctor working for a private healthcare organization in South Africa, Netcare, and my role is working in clinician engagement and patient experience.
Hi everyone, I'm Dr. Anuj. I'm a dental surgeon and a business consultant working as EMEA solution leads for public and private partnerships with a firm called THB, which is a tech and data solutions firm.
Thank you. Hi everyone. I'm Dr. Muji from Congo, the Democratic Republic of Congo. We have two Congos. So I work at Vanga Hospital. I'm in charge of education and also research in our organization.
Hi, I'm James Castro. Thank you for having me. I'll be succinct, but I feel my background requires a little bit more explanation because that's obvious that they're involved in the healthcare, global healthcare program. My background is not so obvious. I'm an investment banker that lives in Southern California. And I was in pre-med as an undergrad and decided to go corporate finance. And I found my way back into healthcare through buying and selling healthcare organizations. I'm now with a multinational publicly traded company in the US, based in the US, that has a fund that has been investing in US-based healthcare companies. And I've been asked to explore ways in which to invest internationally. And we would characterize that as an impact fund, and I've come here to learn from my peers and of course the educators, and boy have I learned a lot, and we're looking forward to sharing a little bit of that today.
Great. So thank you all of you for joining us today. I should say that the topic of our conversation for this is we're going to explore and unpack a little bit more about hopefully finding and exploring healthcare challenges and possible solutions in low middle income countries. And each panel member will share their experience in a moment. But just to say that the views expressed by the panel members are their own views. They're not necessarily those of their organization that they work for or the host that are presenting them today. So let's just go around and find out a little bit more about our panel. So let's start with the panel. Let's start with maybe Olamide. Tell us a little bit more about your experiences more on the ground, but also within this context of low middle income country and the challenges that arise from that.
Thank you very much, Kamal. I'm sure we'll have a wide variety of challenges from the panel members, but for me, I think three key things that stand out in the work that I've been part of in a lot of multiple LMICs is number one, suboptimal coordination. And coordination could be seen at one level, maybe coordinating partners on how they deliver support. But most importantly is how coordination is kept abreast of all the various challenges in the country. So you can imagine with the triple burden of disease or the hydra burden of disease, there's just too many things to be on top of. So in addition to coordinating partners who are doing work, you definitely then need to see a concrete oversight on all the areas of the challenges that are in country. So that's something that's suboptimal coordination. And one thing is also just sheer lack of accountability sometimes. You see that most case studies of LMICs that have really either in one disease area or in successfully built some form of health systems, you've seen that there's a sort of steep rise in accountability, or there's some accountability measures that have been in place. The third thing that I'm hoping that's different, that cuts across, is just sometimes poor continuous improvement habits. So you could do something very well today in malaria, but if you drop the ball and it goes down next year, it means that you probably will not be doing, you'll not be sustaining that effort. So for me, lack of coordination, be it amongst partners, but also on the different challenges that exist in LMICs is one. Accountability systems that could cut across most of the challenges you will hear later. And then that continuous improvement spirit that's not generally not always there or striking at you when you engage in LMICs.
And just before we move, just tell us a bit more about your work.
Yeah, thanks very much. So for me, I'm in the immunization programs at UNICEF. I work on supporting low and middle income countries based out of the headquarters office, supporting regions and countries globally. And what we do, what I support generally is to support health system strengthening, and that is a broad term, but when you cone it down, you could talk about the systems, the WHO's health systems building blocks, for example. So I cone it down on the supply chain piece, and then on ensuring that we use immunization. So I work in immunization, like I said, so immunization supply chain, how do you use that lever to really strengthen the health systems in countries? So you could support the country with buying vaccines, but if you just drop that vaccine at the border, they're not going to get to the arms of the children. So what do you do between the border and the bedside to make sure that immunization programs can deliver these vaccines in a timely fashion? The vaccines are potent. That's a wide range of things, including coating equipment that store vaccines that make sure that they remain temperature sensitive, they remain stable, and they are not exposed to temperature excursions up to the last mile. The health workforce, data systems, ensuring that the governance systems, I talked about accountabilities, continuous improvement, those only get strengthened when you strengthen the governance and governance mechanisms in country. And so you have logistics working group, you have decision maker bodies that you strengthen, the NITAGs. So those are areas that I work in supporting. So capacity building, ensuring that we can have modern coaching equipment in country that will store vaccines, ensuring that the supply chain workforce are trained appropriately, and ensuring that they can just respond in, and then they can look back also and monitor the performance of the system. Because if you're not just monitoring the system, you will not know how you're performing year on year.
Great. Thank you, Olivia. It's good. Nice to hear from each one of you, as you say, a little bit about your work as well. Who wants to go next? Should we get the over to you? Tell us a bit about your work and also some of the challenges that you see as well.
Yeah, sure. So I think, just in sort of thinking about this and thinking about how to present this. So I work in patient experience and clinician engagement. And to kind of position what I wanted to say was that, quite recently we celebrated World Patient Safety Day on the 17th of September. And it was exciting for me to see that the topic for this year's World Patient Safety Day was elevating the voice of the patient, which for me was obviously very exciting because of the work that I do, because I think oftentimes patient experience is sort of the last regarded thing when it comes to healthcare. But if we think about the building blocks of any health system, the three main parts are patients, providers, institutions, right? And we're living in a world right now where the face of the institution is changing, and to some degree, the face of the provider is changing, but the face of the patient will never change. It will always be an individual at the end who has to receive health care. And so for me, I think it's really exciting to see how we're really beginning to elevate the voice of the patient and how that's even been elevated at the level of the World Health Organization. If I look at my own context, locally, I think in LMICs in general, and specifically in my own context, some of the challenges that we face is that, there's not a lot of consistency in terms of how patient experience is measured. So if you look at countries like America, where they have the HCAHPS and it's well sort of entrenched, and even in the NHS is a well-entrenched tool, across LMICs and even in our own context, there's disparity in tools between the private and the public sector. So it makes it very difficult to even understand how you measure the quality of care from a patient perspective. And there's also then the aspect around patient empowerment and patients having agency. So you find that, some of the tools that are often just kind of copy and pasted from high-income countries, patients find it difficult to engage with them because even the doctor-patient, the provider-patient relationship in LMICs is very different. There's power imbalance. And so there's also that need to kind of increase agency amongst patients. That being said, coming back to sort of the other part of our work, which is around clinician engagement, I think one of the things that we see in LMICs again is that, in certain areas, clinicians are very disempowered. And I think Junior will speak a lot about that in terms of his experience. And so because of that disempowerment of clinicians, you sort of have out of the three fundamental building blocks of a health system, two of them are actually quite negatively affected. So from my perspective, I work in a private system and it's very sort of different in terms of how we're able to impact on these things. But I think it is exciting to see in many different spaces how, because of the way that, we're thinking about patient experience, we're finding more and more, especially as new research pieces come out, we'll talk about some examples later, but how the voice of the patient is becoming more and more a key part of how outcomes are measured, how success is sort of defined, and especially in LMICs in this time.
Great. Okay. Well, before we get started, just briefly then, tell us about your actual context. So tell us a bit more about the way you work and the environment, and then we'll go to Anuj.
So my actual context, I work in South Africa in the private healthcare system. South Africa has a two-tiered healthcare system. We have a private and a public healthcare system. I work on the private side of things. So really what we focus on, and I think this is one of the things that we've been discussing, is that in terms of my work specifically, when you're working in the private side of healthcare, patient experience is extremely important because patients are your way of surviving, right? So there's a different way in terms of understanding how we measure patient experience. There's perhaps a different emphasis on it. Because it is so critical to how we do our work. In the same way, understanding our clinicians and engaging with them is critically important to us because we need them to sort of do the work that we do. So part of my work is really building those relationships, understanding those relationships. So understanding how we can better work together to sort of deliver healthcare, because again, coming back to those three building blocks, without clinicians' involvement, without patients' involvement, we really can't, fulfill our mandate. But I think that, looking at my context specifically, because, I previously used to work in the public system, there's a lot of differences. So in the public system, you don't necessarily have that emphasis in the patient voice. And you also don't always have that empowerment or that involvement of the clinician. So from my perspective, having moved or worked in these two sectors, it's been very interesting to see how the ideas around clinician and patient engagement are very different in the private and public sector. And I think South Africa offers a slightly unique view on that because we do have such a sort of robust private and public healthcare system. So you can almost see those differences quite starkly.
Great. Lovely, thank you. Okay, let's keep holding those thoughts. Anuj, tell us a bit about your work and some of the challenges you face.
Right. So my work can be summarized in two buckets, right? Revenue maximization and process optimization. I've been a business consultant for 14 years. I've worked on strategy side of things for almost 10 years of my professional life, but last 4 years specifically after COVID, what we realized was that revenue maximization, process optimization, it's fine, but there are some core fundamental issues. And we work, I work with almost everyone. I work with investment bankers, I work with providers, I work with public health. And the common fundamental problems are around patient and HCPs. That's what we realized, and that's where we started asking ourselves, what are the key solutions, probably how healthcare can be delivered better. And working in LMICs, specifically in Asia and MENA region, what we realized was the West model of delivery of healthcare cannot be applied on these geographies. You can't cut, copy, paste and apply these models. And these systems don't have enough firepower to create a cost-intensive model of delivery of healthcare and then optimize patient care, or even talk about patient care. It cannot be a value-based system if you are doing a cost-intensive business over there. So what we did was we kind of went to real-world evidence, picked that evidence bucket. We picked the tech bucket, we picked the big data bucket, and kind of draft solutions wherein the voice of the patient can be increased in whatever decision making is happening, whatever solution making is happening, how the patient engagement can be improvised. But what we also did was, we didn't left the HCP out of it. If you go around different systems, there is a lot of focus on patient centricity, but people often forget that an essential part of healthcare is HCP. And if you are not HCP centric, you are not optimizing healthcare in any way. So that's where we focus. We kind of harness the power of data. We harness the power of technology. We try to optimize costs through using whatever virtual modes we can. And then we back it by data. Again, link it to the outcomes so that, there is sufficient evidence for other systems to copy and then, develop similar platforms.
I'm going to ban acronyms. So just so no HCPs or anything. So just to remind us again what you were referring to.
So HCP is healthcare professionals.
Sure. So no acronyms from now on. So all words HCPs. But no, thank you. And again, just so tell us a bit more about, just briefly, then we'll go to Muji as well. Your setting. Tell us about the context that you're working in.
So I'm working with a private firm, and
in which area? Tell us which country.
So we work in Asia and MENA region specifically, and I look after the MENA.
That's an acronym.
Sorry, it's an old habit. So Europe and Middle East and Africa. So that's the market that I largely look around, and I work a lot with private players. I work a lot with public health systems. My prime focus is how technology can help optimize delivery cost and improve outcomes. So that's the core building blocks for anything that we do.
Brilliant. Okay, thank you. So tech is now coming to the conversation. Brilliant. Let's go on to Muji. Tell us a bit about your work and your background.
Yeah, I'm a GP, but it's quite different than GP in UK because really different because in Congo you are in fact you all kind of the problem, clinical issues you have to resolve. And my work is to train doctors and also research. So in our system in Congo, it's quite difficult to find a normal specialization. And so thousands of doctors, after they finish the medical school, they are just there. They don't know what to do, where to go. Few of them then can go to Kinshasa University or Lubumbashi University in the south-east of the country for normal specialization. But the Protestant University then has implemented a program of GP. So we train doctors with a high level of skills so they can help for C-section in the village. Especially we are training doctors who must work in rural region. So they can do C-section to save, they can do newborn resuscitation, they can do hernia, they can even do peritonitis, so all kinds of the stuff. So we think that we can provide them that skill so they can solve up to 80% of health issues in the rural region. And that's my responsibility in Vangasat, and we work in Protestant University. So the challenge are enormous. You have so many persons coming from Kinshasa, the capital city, to Vanga Hospital. Even some come from Angola, the neighboring country. Why? Because our hospital has built of almost 100 here to provide good quality of care to the poor. This is our mission, and also to train the doctors. So the health in our institution is good, acceptable, and in the low price because the population have to pay out of the public. But sometimes we have problem we cannot resolve. So you see someone coming from Kinshasa with the cancer, and it can be blood cancer, all kinds of cancer, and then they ask you to solve the problem. You can find someone coming from Kinshasa or Angola with a trauma, femur fracture. You can't do nothing for that, but they ask you. It brings frustration for you, the physician, and also for the person, because when the person came in the hospital, he thinks that he will find a solution, but you are in front of someone who can provide that solution, and it's bring frustration to the person and for you. That is our everyday life. Also, resources. You can find someone, you can do something, but he's so really poor that you are also limited. Fortunately, we have some partners, those who build the hospital, they are American, who build the hospital. Sometimes they help us to pay about the poor.
And again, just to get a bit more feel for your day to day. So you're definitely a GP that's very different from me as a GP. So
yeah, but
don't
different. I work in the hospital.
Right.
I work in the hospital. My day starts by a meeting with medical students.
Right.
We have 50 medical students coming from Kinshasa for the last year training in the hospital, and I'm in charge of 8 resident doctors.
Wow.
So Monday, Tuesday, I start with meeting to assess difficult cases we have during the last day. We discuss. If we have solution, it's okay. If not, we can try to connect with our network around the world to discuss what we can do for these patients. We do that 3 times a week. And then after that, I make a round in the hospital to discuss again with the nurse, physician, medical student for some difficult case, if we can find a solution. Then I can go back to my office, think about research and other stuff.
What time do you go home?
Yeah, well, it depends. It depends around 7, but I have every day 30 minutes for physical activity, because in that condition, without physical activity, you are there.
Okay, well, self-care is an important thing as well.
Really important.
Thank you, Muji. James, tell us a bit about your work and some of the challenges you see.
Absolutely. Well, I mean, the first challenge for me earlier in my career was kind of a bit of an identity crisis, because they tell you in transactional roles and mergers and acquisitions in healthcare, whatever you do, don't fall in love with the subject matter. And I broke that rule, which is why I'm here. Ultimately, I just want to get deeper into the delivery of care and understand the difference between a favorable outcome and a positive patient experience. And I ended up going in-house with an orthopedic care company, still in the same merger and acquisition role, but I was on the front lines. I could really more clearly understand payer dynamics. And then I went into reproductive care in a similar role, head of strategy, but again, really focused on the patient experience in that role. Studied effectively US healthcare policy at Brown University, which it really helped me a lot, because the US healthcare system has to navigate lots of regulatory hurdles, and we have an abundance of resources, but lack efficiency. And being here has really helped me understand, some of the basic concepts of coordination have existed from the beginning of time in other regions of the world, and but there's a lack of resources. So pulling all those themes together is central in what I'm doing now. Basically the past 25 years, I've focused on really underwriting risk. If we're making an investment in a healthcare business, we're asking, is this a sustainable business? Are the economics sustainable? It's a patient being treated fairly in this environment, et cetera. So there's all kinds of qualitative and quantitative dynamics. Now bringing that thought process into this realm and understanding, how can we as private investors support initiatives in other markets that could use the support while generating a return? In theory, you have political risk, and then you have execution risk, and you think to yourself, wow, that's a lot of risk. That must mean that we're entitled to a hefty return, 40% annual return on investment or more, and that's egregious. So I have been spending a wealth of time with my peers thinking about different ways to create investment vehicles that mitigate risk, that allow the investor to get in and get out, and leave a functioning system behind that can sustain itself. And we'll peel that back a little bit further later on.
Great, thanks, James. And then, so just remind us about your geographical work area. So whereabouts do you cover?
So I lead the national healthcare investment banking practice for a firm called B. Riley. But we have a $2 billion investment fund, some of which is earmarked for healthcare, most of which is earmarked for domestic investing, some of which is earmarked for international investing, and we're still trying to understand how best to do that. And ultimately, it's subject matter expertise, it's genuine relationship with people who are on the ground and that are now well entrenched relationships that there's a lot of trust and rapport. So I think I'm doing a lot of the work that will ultimately enable us to invest and hopefully encourage other institutions to invest with us.
Okay, thanks. So we've heard from everyone on the panel, and we're going to also divulge a little bit more into a particular case study, but I think we've got a few minutes. So given what you've heard already, and we've covered sort of topics, or we've heard about topics around coordination of care, patient voice, measuring quality as well, two-tier health systems, tech solutions, upskilling in low resource settings. Does anybody have any of their own reflections or questions that they want to share? Yes, and David, and then Sanjay. Thank you.
Hello, my name is David Castellanos. I come from Honduras. I'm project management specialist since 14 years ago, working in the public health system. Thank you for all your presentations and what you have shared with us. What I was willing to share here is that I think healthcare access is one of the things that health reforms have been pursuing for several years. World Bank and Harvard has teach during 20 years a course called the Flagship to train, health leaders in the countries to make changes in the health systems. So far, I don't think it has worked as well as as expected. Personally, was involved into the health reform in my country. Unfortunately, because of financing for the US government, I worked for USAID again. It stopped, and then the country, it was alone implementing it, and finally it didn't work. Every leader that comes from a different idea, and they make a twist to the original reform, and then you have a total new reform that it has no head, no feet, no, it's not a reform, it's not even uniform. It's totally different. So I think there's a lot of challenges, and one of the things here is the access is conditioned most of the times on the opportunity for having enough resources to pay out of the pocket. In Honduras, that's the case. Even in the public sector, over 90% in the lowest quintiles of economic income, they're paying out of the pocket for medicines, for healthcare, or you call it. So that's a big issue here, and it's directly linked to poverty, and I think it's well discussed here. And when we have some models that work, happen exactly what one of our panelists just said. It's overcrowded because the population knows that service work and it's free. I'll go there. And then it's insufficient. And then the model it's destroyed because of this overwhelming demand. So I think that healthcare access will be improved when the conditions of the populations are better. And one of the keys in this is social behavior. So if population gets more educated overall, not only for health, but overall, we know that there's a direct link for improving health systems because they're going to take care more of their health. So I think that some of the new things that we need to start thinking forward is to have more holistic and integrated approaches when we talk about health access, because it's not only having more services open, more medical doctors, because the budgets are not there and they're not coming. And international development funding is getting shorter and shorter and shorter. So I think that's an important reflection that we need to keep in the discussion, because as we think that health systems need to be patient-centered. They need to be part of the solution. And they, at this point, they are not being involved.
Okay,
Thanks.
thank you. Before we come to, did maybe Fitzy, did you want to comment on that? That was an interesting point.
Yeah, I mean, I think there's a lot in that, and I think that speaks to some of the conversations happening around the social determinants of health. And really how, you know, to some of the conversations we've been having this week around how there are a lot of the issues that are being framed as healthcare issues that are actually social issues, right?
Yeah.
And so, you know, the question is really that, you know, it almost is like, you know, the question for healthcare workers and providers is like, where do we draw the line between what's healthcare and what's social, and how do we sort of intervene in these things? But I think the key point that you raised there is bringing in the voice of the patient, because I think a lot of the time, even when it comes to healthcare issues that are potentially sort of on the border of social issues, when we actually bring in patients and when we bring in people, let me not say patients, people into the solution-making process, we're able to make solutions that are more acceptable, that are more adopted, that last longer in terms of their effect. And I think it's really just a mindset change for the people who are making these decisions, right? Because we're so used to, we've been talking about it this whole week, we're so used to sitting in our offices and deciding that this is the program that needs to happen. And I think the shift that needs to happen is that we need to start, like you're saying, with the people and understanding what are their needs. You know, one of the reasons that this is a personal reflection, but when I was in medical school, I studied at the University of Cape Town, and we used to do a lot of outreaches to sort of the poorer communities in those areas. And it used to frustrate me so much, because I used to think so many of the problems that are being faced here have nothing to do with TB or HIV. It has to do with the fact that people are unemployed, they don't have education, they don't have access to sanitation. And so if you start working on those things, like you're saying, then you can potentially improve the health of those people. But it really requires the decision makers to make an intentional effort to include the people in these discussions. It's not going to happen sort of, you know, organically. It requires the people in this room, and I guess all of us on this program, to start making that something that we do intentionally.
Thank you. There was a hand. Sanjay, did you have your hand?
Yeah, thank you. So my name is Sanjay Rishi. I work in the pharmaceutical industry in Western Europe, and part of my role is driving and shaping global health equity strategies in research and development and in access as well. One of the comments from the panel that really resonated is that you just can't copy and paste solutions from high-income countries and paste them in low and middle-income countries. And one of the things we know from looking at history and looking at the literature is that some of the differential health outcomes that we observe, or many of the differential health outcomes we observe between low-income countries, middle-income countries, and high-income countries, are legacies of colonialism. And so I guess my question to the panel is, what do you consider as the responsibility of high-income countries to help address access issues in low and middle-income countries without crossing the line and stepping into saviorism?
Okay, nice easy question. We won't go around the whole panel because there's other comments and there's another case study, but who wants to start an answer for that?
Probably I can start with that.
Okay.
So one of the borderlines where Western should stop and you know, elements should take charge is the autonomy and the decision making. You know, the evidence. While I say that, you know, we have to keep in mind that a lot of research, a lot of evidence on which these policies, these systems, and this infrastructure has been developed is done on the Western side of the hemisphere. You know, the developed system. But that not necessarily means that, you know, it is applicable to LMICs. So LMICs need to start investing on their own evidence generation. They need to start, increasing the share of voice of all their stakeholders. I mean, there are systems, and I can talk about specific countries, but they have not even done the proper stakeholder mapping when they are designing their policy frameworks. All they do is what WHO has said, what UNICEF has said, what US is doing. So that's not the right model, you know. So probably a funding support, probably a support on tech and solutions is what is needed from the West, but the autonomy and the adoption and the implementation needs to be driven from inside out rather than from outside in. That's my perspective.
Yeah, if I can add something, I always say that global health is local health. That means you cannot apply as something has been worked in Rwanda and doing it in Congo, or in Congo somewhere east and bring it to west. Sometimes it doesn't work like that. So I think what we have to do is to work together with those coming from West Country, from UK. When they come in Congo, they have to work with those who know the culture, how the population think, what are the real problems. They can bring solutions that doesn't work. Yesterday we discussed about the planning familiar, for example. They bring for population hormone system and they refuse. They want BTL, bilateral ligation tube. So they have spent a lot of money bringing those stuff in our village, but the population, they refuse this process. But I think working together, starting by knowing the problem in the culture, in the context, will help us to improve. And we must include everybody, anthropologists, engineers, everybody. I think then we can find new solutions, new innovation for our population.
So engagement is a big theme coming through.
Yeah, in terms of developing a sustainable investment thesis, I'm drawn to the concept of public and private partnerships. So, public being the government, I think NGOs are a separate branch. You have the private sector, which can be for profit and not for profit. But I'm really drawn to, and this is where I'd be curious to get Junior's take on this as well. But partnering with an NGO like Partners in Medicine, for example, that had success in Rwanda. Very different dynamics and nuances, of course, than the Republic of Congo, but not irrelevant either. But maybe partnering with an NGO that has historical precedent in other markets and other countries that can partner with local professionals. But as an investor, we view the fact that our money is going in alongside a local government as being a partnership. And we want to get in and get out with a bond-like instrument. And we have the senior priority in terms of getting our money out. But all of these partnership dynamics with NGO and the government, in our view, reduces a risk profile because you're working with people that have the requisite expertise to be successful in those markets. And over time, we'll get a 8% return, not a 40% annual return, and then get our principal and interest out. And the ultimate goal is to build, operate, and then transfer and allow that system to operate in a sustainable fashion without our involvement on a go-forward basis.
That's very insightful as well. Okay, we'll take one more, and then you've got a comment online?
Yes.
Yeah, go on, tell us.
Okay, so this question is from Jake, and it says, is there a recommended patient engagement framework in the LMIC context, particularly for service delivery and access of health products? And if none, how can we systematically and authentically engage patients in health policy development and local health boards?
That's a good question. I think the sort of very short answer is that there's multiple sort of people who are doing a lot of work in this space. And I can't speak for everyone. I can't think of a single recommended framework. But I think what's exciting is that there are a lot of different kinds of things that are coming through. I think some of the things that at least are sort of at a very high level coming through is this idea of localization. So, there are a lot of different tools that are very good, and it's kind of having that balance between global tools that can help you to compare on a global level, but also having tools that are locally contextually relevant. And I think we're seeing quite a bit of that where, whether it's in research or, for example, in some of the work that I've been happy or lucky to do, is having that balance between using sort of internationally and internationally ratified tools, but also bringing in that sort of local element. I think that in terms of, the sort of thinking around how do you bring patients in, there's differences in terms of, the kind of practicalities of how that can be done. One of the things that I find very interesting, and I've seen, part in preparation for this, but also what I'm hoping to do as my dissertation for this program, is around using design thinking or human-centered design as a process. And I've seen quite a few researchers using that as kind of a framework. I think that framework is very interesting because it's founded in the idea of empathy, and really sort of getting close to the people and getting them really involved. But also another key part of that framework is around building and failing fast. So you're not sort of building these like fully fledged solution and ratifying it and then trying to roll it out and then it fails and now it's very difficult to kind of come back and work it out. But you're actually in the process, building in the process of building, testing, failing, refining, building, testing, failing, refining until you're able to come out with something that's very useful. So I think there's probably multiple frameworks, but from some of the research that I've been sort of following and the things that I'm interested in, I would say that design thinking is one of those frameworks that can possibly work quite well in LMICs. And there are a couple of researchers who've actually used it quite successfully to launch different kinds of programs. But I'm sure my colleagues can add. Yeah.
If I may.
Yeah.
Thank you. And I'll go to make that point that, so as UNICEF, for example, and most international organizations, there's a lot of engagement with users, patients, in a lot of the either you call it projects or interventions that have been done. I think one of the challenges is taking them to scale and consistency. Because if I do 5 projects and then I engage patients only in one, I'll see that effect only in one. So for example, we're doing a lot as UNICEF on human-centered design. A lot of them are zeroed around demand generation. And we've seen an uptick in that for most countries now because of the fallout of COVID and the anti-vaxxers movement, and the fact that we had a lot of challenges post-COVID to ramp up routine immunization because of the effect of that. And there's a lot of work in that area. So, but what you're saying, policies generally are also done with engagement across the strata. So it's not just people who sit in the boardroom, pretty much just write a policy, generally taken through the layers of a country health systems generally. So there's a bit, but like I said, it's just skill and consistency. That's usually what could be lacking.
Okay. So last comment from Manoj, and then we're going to move on. And then I know this hands, but we'll come back.
Yeah. So both of my colleagues have been talking about and design. So in my opinion, if you are talking about increasing the voice of patients or your physicians in your policy, it can happen either directly. You go to them, you do surveys, you do assessments, you do outcome mapping, and you come out with an opinion. Or and then there is an indirect way. So that indirect way is very critical and very big building block, which unfortunately most of the systems, specifically in LMICs, countries ignore, and that is evidence generation. And do the fundamental question is: do I know my patient? Do I know my physician? Right? And the evidence talks so much. Your patient-reported outcomes, your real-world evidence. It talks so much. It is in a way the voice of your patient, the voice of your physician. And if we cannot find a way, I mean, how many systems, let's ask that ourselves, how many systems or how many hospitals have a unified data platform? How many can say that this is one patient identifier and I can link the whole patient journey, whole disease profile of a particular patient in my hospital or in my system? That is not there. And that's where the real challenge is. If that happens, the policy making will be much more optimized, it will be sustainable, it will be scalable, and it will be more impactful.
Great. Okay, I know there's hands, so I'm going to come back to the hands. So we have got time at the end for more questions, so save them, and we will come back to them. I know there's things being said online as well. Okay, so already a useful discussion, as you can see, and some important reflections. Let's just now focus a little bit on a specific case then. So we're going to look at a little bit more detail in the Democratic Republic of Congo and find out a little bit more about what you've been saying already, Muji. So maybe you start us off and talk about a bit more about some of the key challenges that you face and see.
Thank you. I prefer to take one of the examples. I have many, but just one example of malaria. We found in DRC. We are from a village, a very remote village, with a kid 3 years old. Start with fever. And what the parent needs, paracetamol, they give paracetamol the first day, and then fever, then paracetamol. At the fifth day, they decide to go to the drug store in the village and bring some medicine for malaria. And then thing comes bad, convulsion, comatose, then they have to go to the health center, the first health center. Then it's night, you cannot travel, you cannot cross the river because there is no boat, there is no bridge. And then you go to the nearest health center. There is no equipment. They cannot do blood transfusion, no staff to take care of a severe malaria. And after 3 hours, the kids died. It's frequent to see this situation in Congo. It means what? It means accessibility. And that can be due to geographical situation of the Congo. You cannot cross the river, the night, you have to walk by motorbike for hours to reach the health center. And sometimes why the parents don't decide to go quickly to the health center because of money. They don't have money, and then they stay at home for a long time. Then at the last moment, they come in the hospital. That is why if you come in our hospital and you can see how much we have kids with severe malaria. I will never forget the situation of conjoined twins. They came very far from Vanga. They called me for around 400 kilometers, conjoined twins. And when they told me that we are sending you conjoined twins, I said, what I will do with these kids? And then I have some friend connection. I started to call. I called them, but one surgeon in Kinshasa accepted to try the operation because it was the first time to succeed with this kind of operation. And it was difficult to transport them from Vanga to Kinshasa. Again, one of my friends helped me with MIF to realize that transfer. And the operation was successful. We saved the twins. They came back in the hospital because the cost in Kinshasa was too high. I accepted that I can take care in Vanga for 1 month before they go to the village. But 1 year after, they called me that one had a fever. It was around 1 p.m. I told them to go to the nearest health center. I don't know what happened. And then they called me around 6 p.m. that she has died. You see how hard it was to me. We have saved them for a very, very difficult situation they was conjoined. But one is died due to malaria that can be first be preventable and treatable. And when I started to talk to the parents, I realized that they didn't have money at that time to go to the nearest health center, and then they delayed. Then the twins died. So we have accessibility problem in healthcare. We are talking about access to healthcare, and also we have the quality of care we provide. I would like that we can talk about how we can improve accessibility to the poor in rural regions and how to improve the quality of care we provide to those populations living in the very remote region of Congo.
No, thank you. Very powerful stories as well. Olamide, did you want to add it from your perspective?
Thanks very much. I think DR Congo, by the way, is one of the most complex countries you could talk about. Anyone who has been engaged in any form of programming in DR Congo, and apart from the fact that sheer size, apart from Algeria, that's the largest country in Africa, in sub-Saharan Africa. So you can imagine, as deep-rooted, we talked about coloniality or colonialism, deep-rooted political challenges up until 2019. I think governance there was quite dictatorial, largely. That was the first time, even since independence, decades ago, that you would have a democratically elected president, and there continues to be challenges. So this widespread poverty, as we've said, and all that. So the challenges are just enormous, but further complicated by what we just mentioned, the fact that there's just different layers of complexity in a setting like DR Congo, and add on top of that the fact that there are peace and conflict situation challenges within the countries, within the country with a lot of terrorism, internally displaced persons, humanitarian challenges. So it's, I mean, it would have been great to talk about a simpler context. So of course, as UNICEF, there's a lot, we almost operate or work across all these layers. And back to your comment earlier, Sanjay, the question would be, of course, high-income countries can be partners. That's the best, because ideally you can't be the ones to lead generally. It has to be partnership, working with people on the ground, supporting organizations that sort of work with, of course, with guidance and with recommendations and all that. There's infrastructure challenges, and I'll come to some of the projects I work on later, but centered around the fact that Kinshasa is the capital, but the distance you get from Kinshasa to the remotest villages is enormous. Just like you're talking about, it's similar in Asia, Pakistan, for example, different provinces, everything goes to Islamabad and trucked everywhere down back to Karachi. So sometimes the design of the health system is generally suboptimal. It's not designed with the thinking that we want to get everywhere. It's designed across administrative levels. So because I'm the prime minister, everything has to come to the center first. And generally, sometimes that may not be the best way to design those healthcare services. So that's something. Also, infrastructure, talking about electricity and how it relates to health. So if I'm a health worker in a remote village and there's no power, or there's power cut, I'll probably close shop earlier than I would on a typical day. If I can't charge my phone and I can't communicate anything out, I'll probably close shop. So I'll talk about an intervention we're also doing in that area to just make sure that we keep lights off and generally serve the community, and use that as a way of also providing access and ensuring that access continues. And again, there's a lot of work that has been done in ensuring that products are financed. So you see that there's a lot of funding that goes into procuring products. But like I said earlier, talked about infrastructure, you need to get the products to the people. Oftentimes also, of course, you need to support the people to get there, because sometimes the distance between where they live and where the healthcare is. But even if we focus on just getting the product down to the last mile, there's no country you get to, DR Congo, as big as it is, the Gambia or Sao Tome. If you walk into the health, either the vaccine store or the medicine store, central medical stores, anywhere, you see that it's state of the art. You'll probably get the same stores almost everywhere in developed countries. The further you go, the more it is not like that, because of course it increases in DR Congo to about 15,000 health facilities, and then to maintain that quality is also not. So how do we ensure that distribution systems are also in place? All that is also beyond the purview of just the health sector. So how, as leaders, do we build bridges between finance team to make, and also contribute to ensure that we can improve the economy of the country, to make sure that we can get more finance towards health and towards health product and towards access.
Thanks, Olamide. I think talking about bridges to finance, maybe we'll bring in James then. From your perspective, what are your reflections on what you've heard about this case study then?
I think it's a combination, again, of for-profit and non-profit investing. I think to humanize and personalize the impact investments going into these regions is critically important. And I think I listened to your interview, Muji, on BBC, and I shared it with a couple of friends, and it's moving. And I think until the investment community and individuals understand the severity and how additional resources can very quickly remedy some of these issues, really resonates. And so I think every time I'm sitting in our classroom looking around my peers, I'm just so honored to be there, because the brain power and the life experiences in that room is something that's not, it's not gonna be there forever. So we're doing everything in our power now through the Oxford Global Healthcare Network that we're in the process of building to remain in touch with one another and with future cohorts. We're already bonding with cohort number 2. All of that combined, I think, is going to open up a channel of investment that hasn't previously been there. So it's exciting.
Thank you. Anuj, any thoughts from you and then Itzi as well?
Yeah, so interestingly, so after listening to Olamide Junior, James, we were 8 months back, we were asked to work for a leading pharmaceutical company in DRC. And we were asked how we can do expansion, more patient engagement, improve access to medicines, critical medicines over there. We went in there, and what we realized was that the problems in that system are not the common problems. They are far more severe than even what we face in other elements. For example, infrastructure, the size of the country. I think more than 90% population is in rural areas. They don't have access to internet. They don't have proper access to electricity. So then we started asking ourselves, how do we solve for a population like this? I mean, how do we improve access like this? We cannot create a digital solution which they cannot access over a mobile phone, right? So we started understanding the supply chain of that pharmaceutical company, and what we realized was because it's so because the margins are so less, there is no room for a distributor in DRC. And because distributor is not there, the pharmacist has to go to a depot owned by the pharmaceutical company, buy the medicine, and it is the pharmacist who is recommending the patient what medicines to take, because HCP is not available there. So these are the problems that we were solving for. And the way we are right now doing it is by engaging the pharmacist who still has certain basic infrastructure that is available to them. And through a pharmacist, we are engaging the physician over there and creating a kind of a coexisting model wherein they can co-manage the patient and have a proactive engagement with the patient, use simple SMSs to inform the patient about their medicines, to profile the patient about what their healthcare needs would be, and then do a proactive management rather than waiting for the time till some emergency happens and we lose a life. So again, as I was saying, solutions from east or west would not fit a particular geography. When you are thinking about a geography, go to the local level, understand that problem, and try to solve that problem. And the most important part of solving the problem is looking from the perspective of stakeholders who are involved at the transaction level, not at the policy level. So patient, pharmacist, doctor, what are their challenges, and can we solve them through tech? Because tech is the only way. Otherwise, cost-intensive models, traditional models in DRC will never work. You can never have the kind of infrastructure that we are hoping for DRC to have in the next 10 years. So either we leave the patients on the perils of that aspiration, or we use tech and data and start solving those problems.
Thank you. It's easy, you want to?
Yeah, I mean, we've been speaking about DRC since the beginning of this program because Junior shared about, his context and his experience. And I think, this is one of those clear examples where there are really social conditions that are driving healthcare problems. And so the questions that you sort of start asking is, how many of these things can be solved by healthcare solutions only, and how much of this actually needs social intervention and governmental intervention. One of the things that I think of from a patient experience point of view, which we spoke about the other day, is around just that patient agency piece. And so we were speaking about how, patients are just so happy to receive any kind of care that they don't even have, there isn't even that room to kind of rate or assess or understand that care because there's just no care available. So anything that you get, you're very sort of happy for. And I think there's a huge sort of piece that we think that's around how do you encourage agency and empower patients to sort of need or desire or demand more. I think there's a lot there around, the societal aspect and how, if you think of things like malaria, even if you think of the example that Gina's just shared now around when, solutions are being brought in, how are people being brought into the conversation? Because I think it's just so interesting, the example that he shared around, an organization coming in with the proposed solution of providing oral contraceptives, which was unacceptable to the community. And, a conversation would have probably completely changed that entire proposal as to what to do in that setting of contraceptive care. So I think for me, looking at the DRC situation, as Olamide said, it's very complex. It's not a clear cut. There is no, we can just do this and it's going to be easily fixed. I think there's a lot of room for responsibility to be taken by parties around the social aspects and the equity aspects and how do you sort of improve that. But I do think, though, just based on what Junia said, is that, the communities there are aware of their needs. We speak a lot about how the patient is an expert in their own health and an expert in their own needs. And I think that from a sort of international point of view, especially with organizations who are seeking to make impact or improve or assist, it's incumbent upon these organizations to engage with the clinicians, with the people, so that the solutions that are being brought in are actually acceptable and desirable by the communities they seek to serve.
Great. Okay. Thanks. So we've heard from everyone thinking about this more specific case study. So let's open up again, because we've a few topics have come up again. Yeah, I see hands go up, so I'm noting them. So sorts of things that come up are thinking about the design of systems, thinking about bridges with financial resource-rich settings and environments, thinking about digital technologies, thinking about the overlap with social and health issues as well, but also thinking about patient-led solutions as well. So opening up to the floor, some reflections. So I don't want to turn my back, so yes.
Okay, good evening. This is Mapu Brunet. I work in the Global South, particularly in Peru, where I was born and raised. So I feel we're speaking the same language in terms of the issues that you have brought. So going back to the topic in terms of healthcare access, I would like to know, what do you think about universal healthcare coverage? And what's the current status in the countries that you work? Are you optimistic about it? What needs to happen? Is there that political will in the corresponding ministries of health? I would like to hear.
The questions about universal healthcare, yeah.
Yeah, in Congo, it's last month, the government has started with maternal and newborn care, firstly in Kinshasa, the capital city. So a lot must be done to make that new project work, I think. And because for me, I really encourage the government to go in that direction. It's at the beginning. I think it can improve, but I think also we should start with a general assessment of the quality of our treatment we provide. If you don't equip your health facility, if you don't train regularly the workforce, those staff must be there before you come with this new project of cover the healthcare. I can take an example. If you go to the maternity in Kinshasa, they say, okay, a woman will come. The government, they say that the delivery is free, but the nurse who works there has not been paid on time. What they do is that to sell their medicine. But now she cannot do that because the government, they say everything is free. So in the other way, it can again work against the government or the program. So I think we should start with a deep assessment of our system. Then we will know what we really need. We implement what we need, and then we come with this project to cover maternity and newborn care. This is just my thought. It can be the same. In the village, you cannot. We have found it with we call it PPF or yeah.
Can you just tell us what PPF is?
Performance-based.
The performance-based payment. In the health center, they say, okay, you go there, the price is reduced, you have a good treatment for malaria. It's okay, but it's bring more corruption and disorder in the system. Sometimes money should be there every month, but it's come 1 year after. During that time, what will do the nurse or the physician to provide care? So in my opinion, we should first build the system, organize everything, and then we can come with this solution.
So nice, honest answer. You had your answer.
Yeah. So my name is Francis Ayomo. I have experience working in health financing and policy, mainly from Nigeria. And I like the case study given about Congo. But I want to draw attention that in several countries, well, like Nigeria, that may not have as complex the issues are in Congo, though have our own contextual peculiarities. The system is that same story may play out in one of the rural communities. And I noticed that the issue of access, if you look at the literature and just relating to his story, largely borders around geographical access. How close are people to services? What I would frame as facility access. When you finally get to a facility, what's the guarantee you actually access a service? And then finally, financial access. Maybe that's close to you. Maybe they can provide the service. Can you pay for it? So one of my questions would be, what are we doing to look at access, maybe call it holistically, to solve that problem? Because sometimes we solve one and leave the other. And particularly for the very poor and vulnerable, you are not getting to the last mile. In the private sector, maybe those may not be problems because the poor person already knows, don't approach the hospital, you know you can't afford it. So you might think you're doing well, but there's just a select group of people going to you. So what can we do in that area, especially with essential primary care services? The other quick comment is around interventions that we do in health systems, particularly in LMICs. Now, if you really look at what several organizations, not to mention names, there seems to be this interest in what we would call high impact projects, drones to deliver blood, technology, like these things are useful. We're not saying they aren't. But if you really look down, in my opinion, the real issues are much more simpler. I know there are a lot of contextual barriers, but what do you think about the kind of interventions, maybe particularly donor funded, that are implemented in LMICs to bridge access gaps? Because in my opinion, again, that's my opinion, I think we're not prioritizing rightly. Sometimes we go for things that look flashy, digital, AI, and whereas maybe what would really move the needle are simpler and even more cost-effective things. So back to the panel. Thank you.
Yeah, thanks for the comment. We've got more hands, but yeah, a response from the panel.
Well, thanks, Francis, for that comment. I think, in fact, like you said, it's the way we look at it is geographical because of distance, social because it could be close, but they're not getting services. So you look at urban slums. There's a lot about urban service provision now, urban immunization, just because of that. People are not very confident to go to health facilities because they don't look like me. I don't look like them. So I'll not go. Then there are gender barriers, both on the side of service providers as women, for example, who should be supported to provide care, but also for care providers who are supposed to take either children or themselves or care for the family. Barriers are, then there's a whole lot of settings around conflict settings in which it's another ballpark. So you're right that all those dimensions are generally important. What anyone generally has to do, and what we do, is to make sure that we're equity focused. So you can't go into a scenario and you think you're just prioritizing or just cherry picking. Ideally, in fact, you should start from where the situations are worse and then you build out. So that's one way of what we do. Sometimes you also have basic package of services. Sometimes people query such because they look at, oh, if you're saying you're delivering a mama kit to a facility, but that facility also needs other things. They need incubators, they need other things, but that's at least one provision that could also spearhead or be sort of like a tracer for other services. So sometimes generally what we do is integrated service packages. You're right between support and strengthening. Generally, you could be right that sometimes development interventions are almost like political interventions, because a politician will want to build a road than pay for teachers' salaries. Because I mean, you build a road, you can cut the tape and all that. So I think as leaders, generally the onus lies on us to continue to push the lever to ensure that investments are prioritized appropriately. And I will move majorly from support, which are also equally important. So depending on the setting, if you have an emergency, an humanitarian challenge, of course, you may not be talking about strengthening at that point. You first want to assuage the condition on the ground. But as you move from that humanitarian to development in a continuum, and how you can build resilient systems to adapt either in a humanitarian condition or in a development condition is extremely important. So they're not straightforward, or they're not just, you can not do strengthening. Sometimes if you are also the donor, you probably want to invest in something you can measure impact today, rather than in 10 years. So it also goes back to what we mentioned earlier about accountability. Once you say accountability, because sometimes when you say you're strengthening, it's like you're putting investment in a black hole, you know, and then you're not seeing. So patience is important to see the results. Sometimes 10 years lead time to see the results. So everyone that patient also.
Yeah, I'm just pause. I want to get more of the audience involved as well. So I think you had your hand up as well.
Thank you. Hi, I'm Anne-Marie. I'm a consultant transplant surgeon from Austria, and just building up on what you said, and I find this as the roundtable is solving healthcare access. I think we have different problems, or we can call it also different opportunities where we can, because what I find very important, for example, is like organ replacement therapy. You know, in many areas, you do not even have access to renal replacement therapy. So I coming from the sector of transplant, and there are often initiatives, if I may like it or not, to say, oh, we need to build up a transplant program there. But when you then talk, and this is where my interest in for global healthcare comes, when I talk to a colleague from South Africa, for example, who says, yeah, you know, if we could do liver transplant from brain donor, first of all, we do not have the neurology assessment. Maybe it is another donation, and then they are 300 kilometers apart from us. And if there is the infectious disease or there's a renal problem, so I think there are two sides. Or I think this is the patient-centered medicine. Patient-centered is always because we want to deliver the best. But what you said, I think it's so important, is the access to some basics which need to be there, even if I want to treat my infectious disease problem properly. There is this huge impact of fighting like organ failure, and you know, to help people out of their acute kidney injury. What, you know, if it's maybe not like in a different world, we say it's not life prolonging, but in the acute term, life saving. And this would also help, and this would be very interesting, maybe James, how you say it. How do you bring an investment to bring in this substantial organ replacement therapy, and then in different cultures, and what would we need to do that the digital healthcare doesn't say, okay, it's not my point, I cannot do anything in this, but this would be, I think there are two worlds coming together. Some basic needs, what's absolutely standard and normal for maybe a high income country, but really important and not even there. And this is like, according to WHO, it's not even existing, like renal disease is a neglected disease. They do not even look at it. And we know from the Lancet Global Burden of Disease that this is a major burden, what we have with diabetes, hypertension, not even to talk about, you know, other neurological diseases we have.
Okay. I think there's possibly a comment for everyone here, but maybe let's go with James, because your name was mentioned as well. Do you want to?
Yeah, I mean, in that instance, Emery, it's, yeah, a service is being provided to the population, and in that instance, in most instances, the government is our customer, is our payer. So what we would endeavor to do is protect our investment by having a first right at the income generated from the services provided. So we would charge a fee to the payer in that instance, and maybe it's a 5 to 10 year return on our investment plus we'll call it interest rate, if you will. That is how we would view it, with the view of, again, over time, it's a self-sustaining economic benefit and obviously greater access to care benefit for that region.
Thank you for the point. Should we take one online?
Yes. So this question is, could one of the panelists kindly share their insights or experiences regarding challenges and successes that they've observed in implementing a system such as national health insurance in low and middle income countries?
So, national health insurance, India recently implemented something similar to it under the brand name of Ayushman Bharat, which was more like a sponsored healthcare system. Then there are other systems, Middle East has a dedicated sponsored healthcare system for Emiratis. The problem or the biggest challenge is how much of that sponsorship is enough to create a healthy nation or healthy outcome. So, and the fundamental answer or the core problem or the solution lies in, do you know the patient journey? I mean, have you mapped the first contact to the final contact of a patient journey of a disease where you are trying to sponsor the healthcare, and what components of that patient journey is cost intensive, infrastructure intensive, and what components are the components which can be taken to the patient, and where what are the components where patient needs to travel. So if that understanding is there, and then if you have your full visibility of your patients, how many patients are there, what is the predictability of a patient, what is the risk of the patient getting sick, then your cost of delivery or cost of sponsorship for a universal healthcare is optimized. Otherwise, it is a blanket rule. You get sick, it is always going to be reactive. You get sick, you get reimbursed, but do we want that? Because it would always add burden to your already burdened healthcare budgets, right? And but if you turn on the coin and if you say, okay, I'm going to predict it based on the patient journey that I know, based on the components or the strength of my system that I know, based on what my patient is going to what is the risk of escalating that situation in the next 4 or 5 years, and how much money I need to sponsor that, then it is much more optimized care, then it is much more mapped care, and the last component is how do I track of what I'm achieving out of universal healthcare or a sponsored healthcare, what my patient reported outcome says, and do I need to reiterate? So it's again, as Pitsi was saying, learn and fail and implement. So that cycle, that vicious cycle needs to be there as the last component.
Quick comment.
Yes, quick comment. I think one of the challenges for health insurance in low and middle income countries, the fact that it's coverage. So and the dichotomy between the formal sector and the informal sector. Formal sectors generally you have it easily. So if you give an example of a university or a teaching hospital in any low and middle income country, the workers most likely be enrolled in the national health insurance. But just go to the transport park where you have informal drivers, just maybe 5 kilometers away, and survey who has coverage on health insurance, you'll see now. So you see offshoots of community health insurance, you see offshoots of the companies, that how you make it coordinated to make sure that the coverage goes really broad, is because eventually, if you're the investor, the question is, do you insure someone that can pay you every month? Maybe not. So how does the government come in to make sure that there's dedicated mapping across the country, and then engages providers that would be willing to enroll people? So of course, but you have to also start from systems. Do we know everybody? Are they already enrolled? In Nigeria, for example, Francis was talking about it, I'm sure you would probably know. There are a lot of databases. How do they speak to one another? Maybe not. There's no one central database. So for example, there's been recent talk in the news about learning from India with the digital database that was done almost countrywide in more than 1 billion country, so population. So that's really a common system that then can be built on to do provide such services like insurance systems.
Great. Okay, yes, more hands. So yes.
I'm an external participant, so I don't want to take away.
You're welcome.
So my name is Sharbani Chakraborty. I'm at the Center for Global Health at Technical University Munich, and I was invited earlier this year to talk to this excellent group, and I got a lot of tough questions. I'm humbled. So since we're in a business school, I spend a lot of my time looking at social entrepreneurship and how it can be leveraged to solve global health problems. So I would love to hear from the panel. There's increasing discussion about the role of the fourth sector. You know, they can be intermediaries at the community level, they can bring in innovation. So how does the panel look at the role of local social entrepreneurs being supported by external donors, instead of donors going in there and doing the thing, supporting local entrepreneurs to perhaps look at innovations? I'd love to hear.
Thank you. So now's your opportunity to get them in with your questions. Who wants to start with a great question?
I can start and then you can add. And in fact, thanks for asking that question, because I think that's one of the examples I was going to give. So we're working on the maybe the easy answer is that yes, I'm definitely for social enterprises, because we can't be talking about social determinants without an economic determinants without trying to solve that also. So one of the things we're working on is that I was giving an example earlier that if you go to any national system in a country, it's generally robust. The more you go down, so if I give you, for example, immunization, let's just zoom in. If you walk into any central medical store, you'll probably find maybe minimum of 2 big refrigerated trucks or big vans for moving vaccines to the next layer. The more you go to the last mile health facilities, the more that responsibility of fetching vaccines from the lowest store is outsourced to guess who? The health worker. So that way, it then becomes the day the health worker feels, I don't think I want to be a charitable person this month. You don't get vaccines or you don't get medicines. So what we're trying to do now is to have a project have an intervention we're calling Drive, which is supposed to engage young persons and community organizations at the last mile, who generally have the spread and the reach because they are there already, to be the ones to go to the last store at the district or province, whatever you call it, and then deliver the vaccines to our facility. You allow the health worker to focus on vaccinating or delivering nutrition services, primary care services. You create jobs because you are then paying that young persons or community organizations to deliver the vaccines to the last mile. What you then do also is that you create that communal ownership, because now only our workers generally do that job. A few countries have some direct delivery where it's by 3PLs, 4PLs and all that, but having community members, maybe even nominated by the community, do that service on behalf of the community probably would also generate demand. And we have a few countries that we are implementing that in, and that would be interesting. So that's one social enterprise that I'm quite engaged in, and that's an area where it touches on not just the program challenges, but also contributes to generating income for young people, others, and create that revolving fund where you can also, you don't have to go back to the donor to get a motorcycle that you've given to a young person, because if he's delivering for 10 days for vaccines or for other commodities, the 20 days he could do commercial enterprises and use it to move people and all that. So that's one practical example that I have to share.
So my answer is very simple. I mean, domain expertise, gatekeeper of partnerships, and establishing opportunities. So when I say domain expertise, any healthcare solution, in my opinion, it is at least 60-70% of the domain, having the local knowledge, knowing the social construct, how individuals, not as patient, but as individuals behave, and what is going to drive a larger social change to optimize healthcare. So that's one role to play. Second role to play is, as a social enterprise, can you facilitate partnerships with global, local investors, but for that matter, with the private partnerships between tech players and the government? Can you be the gatekeeper and open the right doors so that right tools can enter the healthcare system, and then knowing the true cost of care. So it's just not the medicines or the healthcare delivery. The cost of care, you the whole infrastructure, the social construct as it. So what are the opportunities there for any investor or any third party or any external partner to partner and solve those? For example, in the morning we were having a discussion. One of my clients in India was invited to invest in a brownfield project in Gujarat, and they expected a very low IRR from that project. But what they did was they partnered with the social enterprises. They found complementary ecosystems or investment opportunities from where the net return increased 3-folds or 4-folds, and it was a sustainable investment. They stayed invested, and now it's a very optimal and profitable delivery model. So there are multiple avenues, and I think it's social enterprises, in my opinion, are going to play a very critical role as the fourth leg of healthcare ecosystem, and they are there to stay, in my opinion.
And I'll be very succinct, but for us, we don't have a real interest in passive investment. And there's a real opportunity in our minds to affiliate with a management services organization. So effectively an incubator or an accelerator, and offer administrative support, because a lot of these concepts are great. It has nothing to do with the relevance of the concepts. It's really the lack of capital and the lack of resources. So if we centralize strategic thinking and capabilities, administrative support, and of course capital infusion, the likelihood of those new concepts and new businesses succeeding in their markets is much higher.
I'm just going to take maybe one or two more final comments, and then we're going to wrap up. Yes.
Yeah, I think that I just wanted to flag and maybe just expand on one of the challenges that was flagged in the conversations, and that's on the policy and on the legal environment. That's one of the challenges and barriers possibly, but also that I think just listening to some of the comments that have been raised in terms of community engagement, the patient engagement, I think that there's now more and more also solutions that are there in terms of engaging patients and communities to be part of the solutions in terms of how they want that healthcare to be provided. In the case that you gave, for example, one of the issues that's being resisted quite a lot in the policy space is that of the community healthcare worker. In the case that you gave, that was going to be a starting point where we have seen that, community healthcare workers are supporting, at least basic, delivery of care at the community level as the first point of contact before they escalate to the health center facility and even to the tertiary level. And even within that, there's even other models of care that are being developed around even community pharmacy delivery. But those are issues that are contentious, and I think are quite, I think we're talking about evidence-based, innovations. And I think that there's often the resistance between the clinicians to say, oh, that is going too far. How do we know, how do we regulate this? But also how do we collect evidence and data to inform further, decisions that we need to make. So I just wanted to flag that indeed there's a lot of opportunities, but often sometimes the regulatory and the policy environment is not catching up fast enough. And I think that our healthcare workers are so overburdened and too busy because there's just shortages of numbers that they're not having that time to reflect and think, can we really invest time to research and really think deeply? Because all those community bottom-up solutions, I think where they are being documented are seen to be having the impact, but there's a lot of resistance in terms of adopting them and scaling them up further, because that's a real disruptor to the status quo.
No, thank you for the reflection. Final one, I'm afraid, Wei.
Yeah, thank you very much for the panel for the very inspiring discussion. I just want to maybe a little bit back to the low and middle income context of in the global health. And there, first of all, I want to just share that there is a very interesting report about the international aid and the coordination, and especially a case study in DR Congo. And this report published in 2015. And there, the observation is that the international aid is actually ramping up. It's not like an absolute number or the amount is going down, but the observation is that fragmentation is increasing. So this is also reflected probably from that colleague shared in Nigeria and you shared in Honduras, that where even though there seems the need and seems that there are external support, but it does not necessarily mean it can be used efficiently in a country's context. So there, my reflection, and maybe also the question, if the panelists would give a thought and share some of your experience and opinion, is that how does the coordination and the coordination of the fund into the country can be improved, and how the prioritization of using the fund can be more effective and efficient. Who are taking the ownership of making all that decision? Is it donor? Is it the local government, or is it other investors like investment banking? So who's actually taking the lead, taking the ownership of all that decision and really own the outcome? And also importantly, it's about how what should be the way to make all those international aid going into those low resource setting to be sustainable, so the capacity can be really built locally. So it's not just the investment for the next investment. So this is some of my reflection, but I also want to, if there's still time, hear from the panelists.
Yeah, so be the final reflection. So yeah, any reflections?
I think that now everything comes from the top to bottom, and the top can be New York, Washington, or the government. Because if something is being designed in Washington or London, then they come to Congo, they discuss with the president or the Minister of Health. This is our program and we want to implement this in your country. And then you go to the intermediate level, to the province, and then they discuss with the technical level, and they go to the health zone, that is the implementation level. So, and the population, they know nothing. They will just here in your village, we will do this, and in your village, this will be happen. And I think, as we have discussed with Agnes, and I think if we know the needs of the population, and then the population decide to get there, I think then we get the results. The programs are really fragmented. You have malaria national program, you have HIV program, you have TB program, and each program has its own guideline. You see, for TB, we give this treatment, this treatment, this treatment. For HIV, this is the treatment. Sometimes there is no cohesion between the two guidelines. What to do? The same with malnutrition. This is the guideline for malnutrition. This is the guideline for malaria. And for malaria, you have some contradiction with malnutrition. So I think those who are designing this program, in my point of view, should work together in the high level. And before they do that, they have to come down, talk to the population. They can use systematic review. We have learned systematic review. You can know the gap, what's the gap, what we need to implement. But before you go further, then then come down and talk to the population. Then you will understand the needs and can understand how to implement your program, your project.
I think that's quite a nice point to end on. So there's a few people to thank, which we'll do in a second. But I just wanted to reflect that, I hope you've enjoyed the discussion this evening, and also it gives you a sense of some of the discussions we have within the program, but also the richness of the experience and the expertise that the program draws in to hopefully not just share, but hopefully find some of the solutions to some of these big challenges. So let's go to thanks. So firstly, would you join me to thank the panel today? So thank you, panel. And also just to join me to thank Laura and Jen for setting up the day. Finally, thank you to you all for joining us in person and online as well. And for those of you that are staying, do join us for a refreshment and come and meet and continue the chat. But thank you all.